Yes, I am Cassandra Lane, but I do typically go by Kat. And I would like to start by acknowledging that I am presenting today from a Wabaka land, and I am truly grateful to live, work, and play in this incredible country. I will be kicking off the webinar today by providing you with practical adaptation guidance and frameworks that you might be interested in looking into for your own work or just out of interest. So I'll go next slide. So basically, there are various adaptation frameworks and guidance that is available that are directly applicable for questions of equity or for adapting programs for systemically disadvantaged populations or other priority populations in your settings. I will take you through 3 of these frameworks today that have been successfully used and that I believe provide very clear guidance on the how to undertake an adaptation process. Next slide, please. So first up, we have the ADAPT guidance for adapting interventions to new contexts. And this one involves the 4 steps that's shown here in the figure. Step 1 is assessing the rationale for intervention and considering the intervention context fit. Step 2 is planning for and actually undertaking the adaptations. Step 3, planning for and undertaking piloting and evaluation of the adapted product. And step 4 is implement and maintain the adapted intervention at scale. The other thing you'll note with this framework is that it does start before you actually undertake the process with forming an adaptation team comprised of diverse stakeholders. Next slide, please. And then next up, we have the ASPIRE model, or adapting strategies to promote implementation reach and equity. And this framework involves 3 steps. The first, identifying the underlying assumptions. The second step is identifying potential sources of disparities. And the third step is adapting the implementation strategy to ensure that equity is considered in the underlying assumptions and has the explicit potential to reduce disparities. So just another model that's available here. And then next up, we have the roadmap for leveraging implementation science to achieve cardiovascular health equity. This involves the 4 steps that's shown here on the left-hand side of the figure, starting with select and adapt evidence-based practices. Next step is identifying barriers and facilitators to implementation. And third is selecting, using, and adapting implementation strategies. And then fourth is evaluating implementation success of that adapted model. And this one includes these, on the right-hand side, you can see there's critical considerations for every step. And I actually, although this model was made, it was produced by the American Heart Association, specifically for cardiovascular health equity, it is applicable for any sort of public health, health promotion, chronic disease health, prevention programs. And I find these critical considerations very useful, no matter what model that you'd be potentially using. Next slide. So across all guidance, regardless of which model you use, there is a common theme. And what this is that there is a need to identify the causal mechanisms influencing implementation of health promotion programs in priority settings. So this is basically our barriers and facilitators and contextual factors that influence implementation. And this information is essential because it enables us to know where, what, and why changes are needed, so ultimately inform the adaptations. Next slide, please. So this begs to question then how to gather this data. How can we figure out what these contextual factors, these implementation influences, what are they? And what is really important here and what I would like to draw attention to is that quantitative evaluation methods are not really suitable for this question. It is tempting because this is the primary approach that's used in implementation science. And for many of us, it's often very familiar territory, and we call it the comfort zone. But for this question, qualitative methods are key. This is the route that we want to take. And this is because qualitative data allows us to understand the lived experiences and the unique contexts, including the needs and the strengths of priority populations and priority settings. And ultimately, understanding cannot be reduced to numbers if we want to address equity. And then I've just included a few examples of qualitative methods to consider here. For example, ethnography, focus groups, interviews, feedback, consultation, and then the last one, rapid ethnographic assessment. And of course, there are many different methodologies and methods that are available. This is just a little snippet to get our brains thinking about that qualitative space. Next slide, please. And another important consideration is how qualitative research is conducted. So not just using qualitative methods, but how and what methods are being used. And this is because not all qualitative research is equal, and yes, pun intended, especially when it comes to equity. So many systemically disadvantaged population groups have been historically exploited for research purposes, and this is something that's important to consider when working in the equity space. So all qualitative research, regardless of the method, still needs to be founded in principles of equity. So for example, partnerships and relationships, prioritizing voice of community members, participatory research, decolonizing approaches, other ways of knowing. Again, just a little snippet of examples of things that need to be considered in qualitative research for priority populations. Next slide, please. And then since I'm providing practical insight and resources for everyone, I also wanted to share these three excellent resources to refer to when undertaking any kind of qualitative research that has a focus on equity. So on the left side is a paper by Rachel Shelton, and this is an American researcher whose work with historically marginalized populations in the USA has truly been foundational when it comes to equity-focused qualitative research. In this particular paper as well, Shelton describes various methods, qualitative methods, used to promote health equity, and includes some information on data collection, sampling, and analysis. And I believe this would be a really useful starting place for practitioners or researchers who are still considering their options because it's a really good overview. There's also papers on the right-hand side here. So on the top, we have a paper by Demonathan on decolonizing methodologies in qualitative research. And this provides 4 practices that can be used based on decolonization theories. And then below that, we have another paper that comes out of Queensland, so here in Australia. And this is on contributions that non-Indigenous researchers can offer towards decolonizing health research. And I personally have found this very useful as a non-Indigenous researcher working in the equity space. In particular, the reminder that it requires prioritizing decolonizing ourselves and acknowledging the necessary discomfort of doing so. And next slide, please. So in our setting, one of the methods, the qualitative approaches that we are just piloting now and about to employ in our setting for work in rural and remote primary schools is rapid ethnographic assessments. And basically, these are a novel, timely, and action-oriented qualitative research approach. It sounds like marketing. But I mean, I believe it's awesome. But now I'm going to tell you why. So it involves teams of researchers that work alongside and within local settings. So it's really about immersion in the context of interest. Data collection is using various strategies. So for example, interviews, field observations, informal conversations, and photos even. And it is also action-oriented. So the findings can be used to inform adaptations of programs. And the methods can also be tailored for cultural responsivity. So just as an example, Indigenous ways of knowing, being, and doing can be used in data collection and analysis. And of course, that would also require from the onset having an Indigenous methodological perspective. So I just want to draw that to attention. That would be the priority over the ethnographic methodology. And then in the process, rapid ethnographic assessment can also illuminate other unaddressed health needs, and it also builds partnership and community engagement. So you can see through this kind of list of the great attributes of rapid ethnographic assessment that we're really getting some of those equity principles, really prioritizing those equity principles in the qualitative approach here. Next slide, please. And I think this is my last slide, but so in our setting, we have developed an adaptation process that we are just embarking on. So we're getting started on it. So this is still a lot of theoretical drawing together methods and ideas right now. But our objective is to adapt community-based chronic disease prevention programs for priority populations. And our recipe to do so, kind of drawing this all together now, is taking that ADAPT framework that I introduced at the start of the presentation and combining that with qualitative data collection using rapid ethnographic assessments, because that's what's been deemed most appropriate for our research question in our setting. And you can see on the right-hand side here what that kind of looks like in combining the adaptation process with the rapid ethnographic assessments. And I won't go into a lot of detail there because that would take me an extra day. So that's the end of my presentation, I'm pretty sure. And I'm really excited now to hear from our other presenters on what they've done.
Beautiful. Thank you so much, Kat, for that lead in. I think great to hear more about the frameworks that underpinning a lot of your work. So I'm going to touch on a bit of that with my presentation. Um, Lovely to be presenting to you all today. I am going to talk about an example of culturally adapting a health promotion program. So my PhD work was looking at the cultural adaptation of the Healthy Beginnings program among Chinese and Arabic-speaking migrants in the Sydney area. This is under the guidance of Professor Li Ming Wen and Professor Chris Rissell, among some other supervisors. And I'm going to talk to you briefly about what Healthy Beginnings is, and then how and why we undertook a cultural adaptation and the process, and then reflect on some key considerations. So the Healthy Beginnings program, as I said, is led by Professor Li Ming Wen. It's probably over 10 years of research now, but it's a behavioural intervention targeting families to support their children's nutrition, physical activity, screen time, and sleep behaviours. It's led by child and family health nurses, so it's a one-on-one intervention. It started as a home visiting model and has moved to telephone and SMS delivery model. And in both of those trials, it's been shown to be effective at changing children's BMI, but also importantly, those health promoting behaviours. So we know it's effective. Next slide, thanks. So we were interested in how can we leverage this existing evidence-based intervention and do so to support families from culturally and linguistically diverse backgrounds. So we know families experience inequities, particularly around childhood obesity rates, which is of interest for this program, but also generally in terms of access to health services. And we're also very aware that research often targets families that speak English primarily. So we wanted to address some of these inequities and explore how we might improve the acceptability and extend the reach of Healthy Beginnings, working with some target culturally diverse families. Next slide, thanks. So we went to the literature, being researchers. We had a look for some adaptation frameworks and models. The two we used, so they sort of put them in two categories. We've got content models who look at specifically some guidance around what to adapt, and then there are process models which look at how to adapt or the steps that undertake. So the two that we used are commonly used for a reason. I think they're nice and clear and give some good direction. The ecological validity model has 8 domains to consider, things like language, metaphor, content. It sort of steps you through some of the what aspects. And the process model we chose was a model specific to cultural adaptations of interventions. So I'll talk you through that in a moment. But I guess I want to highlight the ADAPT model that I talked about was published in 2021 when we'd already undertaken our process, but I really like that model. And it has a really clear focus on the implementation angle as well. So this model we use, the cultural adaptation model, really looks at purely the steps to adapt the intervention, whereas adapt model that Kat spoke to really incorporates that next step of implementation and scale up. So I'll talk you through these now. Next slide, thanks. So these are the 6 stages of that adaptation model. And for our project, we went through stages 1 to 5, and I'll tell you about that last stage at the end. And the stages 1 to 5 we did over a couple of years. And this was part of the research team and a broader project team. So I absolutely was not doing this solo. Critically, it was part of a broader group, and was really supported by the infrastructure of the existing Healthy Beginnings program. And I'll talk to you a little bit more about the collaborations as we go forward. But yeah, just wanted to highlight that this is definitely a bigger picture project. Next slide, thanks. So those first 2 stages were really about sort of painting a bit of a picture before you launch in. Stage 1 is looking at some initial considerations, really needing to be clear about why we were adapting this particular program, and looking at maybe then any underpinning assumptions and the core components of the intervention. So we did a secondary analysis of the Healthy Beginnings intervention and found that there was poor engagement, retention, and behavioral outcomes among families from linguistically diverse backgrounds. We had good engagement. There was about 40% of participants who spoke a language other than English at home within the Healthy Beginnings telephone delivery intervention. So we had good engagement, but I guess looking at comparatively families who spoke English primarily, some of those those outcomes were poor among families from linguistically diverse backgrounds. So we knew there was a need, and that yes, it could fit, but we could do a bit better. We looked at the program logic. We wanted to really understand what were the core components of the intervention. I'll talk to that in a moment. And then stage 2, we really need to do that information gathering, one from the literature, but 2, importantly, from stakeholders. And again, I'll go back to what Kat said earlier, qualitative work here was absolutely key. We needed to hear from stakeholders, particularly families themselves, around what unique factors were there for those families in terms of those health promoting behaviours, but also the intervention more broadly. So those really were key in understanding what we might adapt, how we might adapt. So also talking with families, we talked to health professionals. We talked to mostly child and family health nurses who engaged with families from Arabic and Chinese speaking backgrounds to understand what their point of view was in terms of the key messages we needed to get across in this time. Next slide, thanks. So stage 3 was pulling together that information and coming up with some preliminary cultural adaptations. As I said, we really unpacked what were the core components, what were the components of the intervention we felt were essential for getting some of those behavioral outcomes. So what were the core components for the effectiveness of the intervention and making sure they held strong? And then what were the adaptable components of the intervention? And we looked specifically at delivery personnel, so importantly engaging a bicultural nurse to do the delivery, but also the content and the materials. So the SMS, the booklets, and the call scripts were adapted and translated and presented differently for both the Chinese and Arabic speaking groups. This was a very not a long process, but there was a lot of back and forth. There was a lot of stakeholders involved. Importantly, there were representatives from both cultural groups that were essential for this step. If you just change to the next slide, I've some example content here. This is just some of the intervention material for the Chinese-speaking families. It's maybe a bit small, but you can get the gist. We tried to make sure there were plenty of pictures, that they were representative. We drew out some of those initial considerations and made sure they were incorporated in the preliminary adaptations. So, for example, tummy time was not a concept that a lot of the families we spoke to were familiar with. So we really tried to draw that out and make it a bit of a focus, which you can see one of the images there. So that's just one example of the content that we really worked to adapt. Next slide, thanks. So stage 4 of the process model was to do a preliminary test. We set this up as a feasibility study. We wanted to pilot our adapted materials and intervention with families from Chinese and Arabic backgrounds. And the intervention design was the pre-post, sorry, it was feasibility evaluation design. We did a pre-post survey and then some follow-up interviews with the participants and also staff. And we were looking at feasibility and acceptability outcomes primarily. Next slide, please. So we engaged over 160 mothers in this pilot study, and largely it was, from our results, feasible and acceptable. You can see the retention was very high. I think when we unpack the engagement with all, there were some differences there, but I think our quantitative information said it was mostly feasible. The acceptability information is really what interests me. This is where we interviewed our the families who participated and also the staff who were engaged. Really strongly, there was a value in having done this. There was, sorry, if you stay on the previous slide. Thanks. There were almost all of the mums that we spoke to really valued having a nurse who could speak to them from their cultural background in their language about things that were relevant to them. That was absolutely came through loud and clear. Also having resources in language, particularly to be able to share among family. And there was also mostly acceptance of the online telephone outreach sort of set up for our delivery. Next slide, thanks. So stage 5 is refinement. So based on the pilot work, what do you then change in the program? We did that based on our pilot study. So as one example, a lot of families talked about this being a one-on-one nurse and mother intervention, and that there was an interest in engaging partners and husbands and also family more broadly, particularly grandparents. So I think if we were to move it to the stage 6, that would be one of the refinements. There were a sort of series of them that we could modify from that pilot test. Stage 6 is an effectiveness trial. This isn't absolute ideal. We want to look at the original and adapted version and be focusing then on behavioral outcomes. So we see the same effectiveness when we are putting up the original versus the adapted version. We've pitched this for a few grant opportunities. We have not yet been successful, but that is the ideal stage 6. And I'll just move to the last slide, thanks. So I think considerations for adaptations, I want to really highlight this was a research project. It was quite a rigorous adaptation process and it did involve significant time and resources. I totally appreciate that. On the ground, cultural adaptations might look quite different to this, but this is an example of the process that we took. Stakeholder engagement is absolutely essential throughout. Again, as Kat mentioned, if you can come up with that stakeholder group initially and have that sort of drive the process, that again is an ideal. I think we found balancing the fidelity, so the way that the intervention is initially set up versus fit with the target group can be challenging. It's a bit of a balance. You don't want to overhaul the whole thing, but you also want to be really true to what the target group want and are telling you they need from that intervention. And I already said this, ideally trials would be ideal to demonstrate effectiveness once you've done the adaptations. So I think on the ground, really meaningfully will be that engagement with your target groups and stakeholders presenting those populations. I think it needs to be, as you can hear, more than an adaptation, more than a translation. It needs to be, I guess, a deeper understanding and adaptation process. And I think the systematic approach really served us well in this example. And a lot of the process models that is part of it, taking a really wise approach to be systematic and transparent about your adaptations. Next slide, thanks. This is a very big thank you to everyone involved. I do want to recognise that part of this work was funded from the CRE there, from a partnership grant, and the Sydney Local Health District really led a lot of this work. It was across other LHDs, but Sydney Local Health District have been critical. My next slide is just some references, so no need to stay there, but it will be circulated in the slides. So thank you so much. That's one example. Danielle is now going to talk again about Healthy Beginnings, but a different project and a different approach. So I'd love to hand over to Danielle now. Thank you.
Thank you, Sarah, for your amazing presentation. Good morning, everyone. My name is Danielle Jawad, and I'm a PhD candidate at the University of Sydney, and I'm also a project coordinator at Sydney Local Health District, part of Population Health Research and Evaluation Hub. And like Sarah mentioned, today I'll be sharing with you about the process we took to develop the Healthy Beginnings web-based platform, which is also part of my PhD project. Thank you. Next slide, please. So I thought I would share just a quick background. As we know, overweight and obesity among children and adolescents remains a global public health issue. And we know that there's inequalities that exist in the distribution of childhood obesity, especially among culturally and linguistically diverse communities. And there are several reasons for these disparities. Some include language barriers, limited access to resources and healthcare services, and also cultural traditions. And most obesity prevention programs focus on English-speaking population. Next slide, please. So Sarah gave a bit of background, but Healthy Beginnings is a health promotion program, and it aims to improve infant health behaviors to ultimately prevent the early onset of childhood obesity. It has been running for over 15 years now, and it's led by Professor Li Mingwen. And it does consist of a suite of programs. So it did start off as a nurse home visiting trial, and then there was an app, and they integrated it into existing services. And then they delivered the Healthy Beginnings program through telephone coaching and SMS, which is the chat study. And then there was a cultural adaptation of the chat into Arabic and Chinese, which Sarh Marshall just presented. And now we are working on translating the Healthy Beginnings program into an interactive web-based platform. Next slide, please. So my first PhD sub-study that I worked on, and this was before we started the development of the Healthy Beginnings website, was a systematic assessment of infant health websites. And I used a range of validated tools to measure the interactivity, the quality, readability, and content. And you can scan the QR code if you're interested in learning more, but briefly what I found was, if we just go to the next slide, please. So briefly, I found that the overall interactivity of websites was predominantly poor. Very minimal websites were culturally responsive, and there were very few websites that had a readability level of lower than grade 8, which is the government recommendation. And most of the websites got an adequate rating for quality. Next slide, please. So what we found was missing was that there was no study addressing early lifestyle behaviors in the first year of life using a digital web-based platform that had considered cultural responsiveness and health literacy. And there was a need for a more cost-effective and sustainable mode to deliver evidence-based intervention on early obesity prevention. Next slide, please. So we aim to do just that, to develop an interactive web-based program that addresses health literacy and cultural considerations. And also this website was developed in 3 languages, in Arabic, English, and Mongolian. And the reason we chose Arabic was because it was an established community within our district, and the Mongolian community was an emerging community within our district, and they really needed, the help and resources. Next slide, please. So in phase 1 of the development, we conducted several sub-studies. Like I mentioned before, we did a systematic assessment of websites. We did some content analysis of parent posts on child behaviors. We also had some consumer engagement. So we had an online survey and telephone interviews with parents just to understand where they go to access child health information and what engages them to use online resources. We did co-design workshops with parents. We had a Facebook consumer group, and we also had some stakeholder engagement through a committee and also some health professional workshops. Next slide, please. So co-design was a really important part of the development of the Healthy Beginnings website. And what co-design is, it's a consumer engagement process that includes engagement across all stages of the research, so we can gather feedback, input, and ideas throughout. And what this process ensures is that the final product outcome is more accessible, is inclusive, and is culturally responsive. And our workshop focused on 4 aspects, where we got feedback on content, on branding, interactivity, and prototypes. Next slide, please. So we had 2 modes of delivery for the co-design workshop. We had the face-to-face workshops were conducted with Arabic-speaking mothers, and they were facilitated by myself. And then we also had online workshops with Mongolian-speaking mothers. They were facilitated by a Mongolian-speaking cultural support worker. And we also had some online workshops with English-speaking mothers as well. And through this process, we identified some pros and cons in delivering workshops in these ways. So with the face-to-face workshop, I found that there was the immediate interaction with parents. I greeted the parents, I held their kids, we had a chat, and that really helped with the rapport building. There was also the observation of non-verbal cues, such as gestures, facial expression, body language, and it really helps you read the room better and facilitate better understanding. There's also the hands-on collaboration with prototypes and materials that makes the workshop more engaging. And then there's the social connection and community building among participants. And really, after a few sessions, I found that the parents got along really well. They even started having play dates with their kids. It was just like an overall friendly experience and a really nice experience conducting these workshops with them. Now, the cons there's a travel requirement. So sometimes if parents can't make that specific time or date that you had scheduled, you won't get consistent attendance. And there's also, the arrangements such as venue booking, catering, etc. Now, with the online workshops, they're more accessible, there's flexibility in scheduling, and it's cost efficient. However, you may face technical challenges, especially if parents aren't familiar with the platform you're using. It's harder to interpret the nonverbal cues. Parents start experiencing digital fatigue, especially after, an hour and a half of the workshop. They start getting tired, and then it's also harder to make the workshop as interactive as a face-to-face workshop. Next slide, please. So as part of the workshops, we reviewed content, and one of the activities we did was amending words or phrases. And it was interesting because the Arabic-speaking mothers, they all came from different countries and they had different dialects. So it was nice seeing them work together to come up with terms that were understood by all of them. Another activity we did was getting feedback on titles and subtitles, so like a card sorting activity. And we also did some comprehension testing, so asking them to describe what they have read in their own words and describe an action that they would take after reading certain content. Something I would add on this slide in terms of the content was that parents pointed out that they didn't want us to change any of the common terms that health professionals use or the high literacy terms that health professionals use, but instead they wanted us to define that term in brackets next to it, which would help and give them confidence to communicate with their doctors or health professionals. Next slide, please. We also got input on branding. Something that parents pointed out when we showed them one of the prototypes was they didn't understand what the globe meant. And then they told us that they wanted us to write the word language next to it. And that's why with these workshops, it's really important to go in with an open mind and not assume knowledge. And something we did after the workshops was we wrote a reflection document with all the key findings, and anything that was relevant, we would send it to the developers to implement in the next prototype. Next slide, please. So another thing we did was get feedback on interactivity and features such as images, videos, and infographics. And there was also a video idea that was actually generated from the workshops, and it was suggested by parents, where they expressed that they had difficulty navigating health services in Australia. And they wanted to, because it was so different from the health services in their country, and they wanted to help other mothers with that. So we got them to review the video script, and then they, some of them also participated in the video, and the video is on our website now. Next slide, please. So something that really motivated parents in these workshops was showing them the prototypes that incorporated their suggestions. They got really excited, and they just got really excited and happy that we were actually taking their feedback into consideration. And we also found that some in-language suggestions could also be applied to the English versions as well. Next slide, please. Thank you. There was several steps that were involved in the content development process. So the content was first reviewed by myself and the team, and the child and family health nurses as well. And then the content was reviewed from a health literacy lens, where we used several tools. So we used the Health Literacy Online Guide, which is a guide developed by the US Department of Health and Human Services. And basically, it's a step-by-step guide for developing health websites that can be easily accessed and understood by users. We also used the Shell Editor tool, which is a tool developed by Sydney Health Literacy Lab. And basically, it gives you an indication of the readability grade, whether there's complex language and passive voice. And we also used an AI tool that helps provide recommendations on how to structure and simplify the content. The content was then reviewed from a cultural lens, where parents reviewed the content in the workshops, and then the content is now being reviewed by a professional editor on the website. Next slide, please. We can go to the slide after that, please. So basically, for the Facebook, it was used to get ad hoc feedback during development. And we got some feedback on like tagline, on feedback on SMS, recipes, checklists, and several other tools. And a strategy that we used to increase engagement was doing a $20 weekly draw for those that interacted with our post on Facebook. Next slide, please. So we are now at stage 2 of the Healthy Beginnings web-based platform project, where we want to test out the website. So we're currently recruiting participants that are in the 3rd trimester of pregnancy or have a child younger than 3 months of age. So if you know anyone that is eligible, please let me know. And so we have commenced the recruitment. We plan on doing baseline survey and then a 6-month survey after they use the website. So we'll give them full access to the Healthy Beginnings website, and then we'll conduct some qualitative research. So we'll gather data through the data analytics on the website and see those that were highly engaged and those that were not that engaged on our website, and have conduct some interviews with them. Next slide, please. So this is how our website is looking like now. And then on the next slide, you can also see one of the articles that is in Arabic as well. And next slide, please. I thought to wrap up the session, I would share some lessons learned throughout this process. So I think it's really important to choose a technology platform that is user-friendly, that is accessible and engaging if you want to conduct any workshops online. And I think the best way to choose the platform is actually going to the community that you want to engage and asking them what they're comfortable with or familiar with. Time is critical, so you want to schedule your workshops around when parents are likely to be available and engaged. So you want to avoid school pickup times, for example. Something that I found really important was that the workshops were conducted in language. Mothers were more comfortable, and you can feel a sense of relatedness. Another thing I found very helpful in engaging with these communities was sharing a personal experience. It created a safe and open space and broke that researcher and participant persona, and it made us more of a team. But I wouldn't share too much to not influence their answers. It's also very important to be flexible and not have a lot of expectations going into these workshops. Sometimes I found that parents needed to attend to their kids, they needed a mental break, or they started having side conversations that was not relevant to the workshop, but I would just engage with them and slowly direct them back on track. It's also important to take their feedback into consideration and showing them that you're doing that. And we did that through showing them the prototypes. And of course, incentives, you want to, reward them or thank them for the time they're spending with you. And something that I would add is that another key lesson we learned is that unexpected challenges, especially in the digital field, can be turned into opportunities. So our developers actually went into liquidation, our initial developers went into liquidation during the development when it was about 80% complete. And basically, we used that extra time to our advantage. We thoroughly reviewed the content from a literacy perspective, and we did more workshops with participants to gather additional feedback to improve the website design. And finally, I'd like to acknowledge and thank the project team and all the investigators on the project. Just on the next slide. And that's it from me. Thank you.